Hello, everyone. My name is Anna Valenzuela, and this presentation for this week is related to social determinants of health, overall related to diabetes and overall global health. Definition of social determinants of health, according to our text, beyond biological processes in the human body and the disease-causing germs that are determinants of health, health outcomes have social origins, such as in the way people live and work in their economic and political systems, known as the social determinants of health. For example, in type 2 diabetes, we have our genetic predisposition. We have our biological factors. For example, Latino Hispanics are twice as likely to get diagnosed with type 2 diabetes versus those that are non-Hispanic white. But also, where were people raised? Do people live in an urban or a rural community? What about access to health? So there are so many aspects related to social determinants of health. And this figure came from the book, our text, and I really liked it, and that's why I put it on the slide. We have our general social, economic, cultural, and environmental conditions that impact our health outcomes. So we have our agricultural and food production. As you know, there has been the movement, the fast food movement for those that are too busy to cook. So that increases the intake of more processed foods. Processed foods are easy, they're quick. Fast foods are very quick. A lot of people are working in the families and they just don't have time to cook and make something like brown rice with chicken breast and non-starchy vegetables. Also, education. Not only do we have education attainment here in the US, we have education attainment throughout the world. I'm a diabetes educator, a registered nurse, and I've worked with different cultures thanks to the institution that I work at, where we really just see a diverse group of people. I have worked with those population groups coming from, for example, Mexico or Central America. And I've learned the hard way. I have to ask, hey, how much education did you get? Some will say third grade, or some might say, hey, I never went to school. So that tells me if I hand somebody some handouts, I might have to hand out some handouts with pictures versus something with writing, or something as simple as math related to how many units of insulin somebody may take for their diabetes. And let's say I say, hey, take 1 unit for every 10 grams of carbs. So if you look at 60 grams, 60 divided by 10 is 6 units. Math that may be simple to all of us here in class may be something that some may not know how to do. And I found out the hard way with one case, and I felt bad that this is something that I did not assess before moving full force with using an insulin to carbohydrate ratio and calculating insulin for carbs. Also, the living and working conditions. Recently, we've been trying to get some people in to see us with very high hemoglobin A1Cs. We're talking about the 200, 300, 400, 500 range. I remember calling one family, a Spanish-speaking Hispanic Latino, and I said, hey, your spouse really needs to come in. And he said, well, she's working and she doesn't have time. So what may be occurring is that they may be more worried about paying the rent versus seeing the physician. And people may not experience the signs and symptoms of high blood sugars. The bodies get used to it. So there's a lot to look into when it comes to the living and working conditions. And does her boss let her take time off of work, even though it's illegal to keep somebody from seeing their medical team? That's easier said than done in different work environments. Then we have unemployment. The medical insurance here in the US is often provided by employers. So when a person is unemployed, do they qualify for Medi-Cal? And if they receive Medi-Cal, Medi-Cal is limited in providing the right kinds of medicines and monitors for diabetes, so forth and so on. Water and sanitation. This is definitely an environmental condition that impacts people throughout the world. We can't forget the various outbreaks that we've experienced in recent history that has a lot to do with the water and sanitation. And let's not forget the Flint, Michigan water crisis. That's definitely fresh in the minds for those that suffered from intoxication caused by the water. And just overall healthcare services. How are the healthcare services that people are receiving both in the US and around the world? Are they good healthcare services? Are they so-so? And are people getting the right kinds of tools to succeed, such as basic health education? That's definitely an interesting question. So our text goes into these key terms and conceptual frameworks regarding related to the social determinants of health equity. Remember, equity has to, everything has to remain balanced and fair. And we have to avoid unfair, avoidable, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. Also, health inequities is related to systemic differences in health that can be avoided or remedied that are therefore viewed as unfair or unjust. Health inequality refers simply to differences in health between different individuals without a normative judgment about those inequalities. And let me stop there for a minute. I recently called a family, hemoglobin A1C was, I believe, 14%. So we're talking about blood glucose values in the 400 range. And this could apply to any part of the country. Hispanic, Latino, this gentleman did have a gap in care where he retired from his truck driving job. And his wife also retired because she was actually a CNA for our healthcare institution. So there was a gap in care where they had not yet qualified for Medicare healthcare services. He already had pre-existing diabetes and did not take medicines for 2 years. So when he finally reestablished care with a primary care physician, he was found to have a very dangerous hemoglobin A1C, very dangerous. He wasn't acutely ill related to it. However, what's interesting about this case was that on the record, on the chart, I read that he was diagnosed with retinopathy in the past. What I considered an experience that was where he experienced an inequality was that what she did is she put him back on an oral agent, a pill called metformin, which doesn't do a whole lot for blood sugars in the 300s or 400s. And she referred him to an endocrinologist, which was, I want to say, 5 months away. And the only reason it was 5 months away, she wanted him to, how can I say this, have a Spanish-speaking endocrinologist versus just a general endocrinologist. And the wait was too long. And what she should have done, in my opinion, although I'm not a physician, I'm a registered nurse, is start him on a low dose of insulin, just, long-acting insulin such as Lantus. Put him on 10 units. Let's get those 400 blood sugars into the maybe 250 zone. And in between that visit and months away, he could have suffered acute illness, need for hospitalization, or more comorbidities related to diabetes. Both the patient and his spouse agreed to see me for diabetes education. And with a little bit of investigating and detective work, I was able to connect him to an endocrinologist who actually spoke Spanish. And she started him on some insulin and ordered a continuous glucose monitor, in which Medicare does pay for if you're taking insulin or a pill that can cause low blood sugars for diabetes. So that's a story regarding to health inequities. A person just not, I don't think he was treated right, or did the physician pass the buck I don't know, and I'm just really happy that I was able to connect him. So his diabetes is not perfect. Last time I saw him, he's in the 250 range, 180 range. And we added a secondary insulin for him to cover his meals. So he will get better, and I hope to see him again within a couple of months. Other key terms or conceptual frameworks, the upstream concept related to government policy and international influence over health. So when it comes to the medical visits, healthcare coverage, this is probably an upstream battle, not only in the US, but throughout the world. In the US alone, there was a lot of controversy behind the increased cost of insulin and for those living with type 1 diabetes and whether or not they have the right to live or not, because some were cutting their insulin in order to pay rent. They no longer had medical insurance that they had under their parents, these young adults, and a couple of people died because they had to ration their insulin. So it's very sad. And do people here in the U.S. have the right to live? I mean, the cost of insulin shouldn't be so high where a person prefers would turn to pay for rent and ration it. That could suffer both acute illness or even death. Very sad. Psychosocial factors, just seeing different clients from different parts of the world. In my profession, there are definitely lots of fears related to taking an injection for such as insulin, or taking an injection such as the medicines that are injectables. You may have read about Ozempic. That's an injectable that you take once a week. So psychosocial factors, or maybe fear, there may be a myth related to injectables or medicine in general. I had a gentleman come and see me with an A1C of 14, another 14%. And he said, well, my entire family relies on insulin and I don't want to depend on it. And I said this politely. I said, well, I hate to say this, but the body does rely on insulin and depend on it to live and survive. So I actually talked about the natural history of insulin and how it was discovered, and the whole history. I really dug deep with him, and I said, you come when you're ready. And we don't want to see you get sick as a result of uncontrolled diabetes. And of course, there are physiological and biological factors. Remember, we have our genetics, we have the aging process. Men are more prone to diabetes versus women. A woman with a history of gestational diabetes is more prone to getting type 2 diabetes later on in life. We have our BMI, our height weight ratio, and also just some lifestyle factors such as activity or food. To take this further on a global level, we have here this chart represents strategies in tackling both structural and intermediary determinants of health. So we have the policies and stratification to reduce inequities and mitigate effects of stratification. So how do we, I mean, inequalities, how do we target these inequalities? We also need government policies to reduce exposures of disadvantaged people to health damaging factors. And this could be related to environmental factors. Also, in where people live, certain neighborhoods are dangerous. There could be violence. There may not be parks for people to safely exercise in. Also, how's the weather, especially during the summer? Are you living in the desert where it's currently 110 degrees out there? And also policies to reduce vulnerabilities of disadvantaged people, such as the elderly. Right now it's everything these days with our smartphones. It requires an app and a login and a password. And also what's interesting is that despite advertising and social media, television, a lot of people don't know about diabetes, what it means, what's an A1C, continuous glucose monitors for those that take pills that target the pancreas or take insulin. And so there definitely needs to be more outreach out locally and globally regarding diabetes. According to the International Diabetes Foundation, diabetes around the world in 2021, there were 537 million adults between the ages of 20 and 79 living with diabetes. It was estimated by 2030, which is right around the corner, 643 million would get diagnosed with diabetes. And this is a key fact right here. 3 in 4 adults with diabetes live in low and middle income countries. This is another image that came from the International Diabetes Foundation, and I was astounded at the numbers related to diabetes around the world. Uh, Here on the left, here you see the Americas, Canada, South America, and it is projected that by 2045 there will be a 24% increase in diabetes, which is astounding. But let's go down and look at South America. Wow, 50% increase, which is another astounding figure. Then we have Africa, which is even higher, a 134 increase in diabetes. The Middle East, North Africa, 87%. And in the Western Pacific region, an increase in 27%. But in Southeast Asia, 68%. Europe still is low at 13%. And okay. And I went ahead and looked up a couple of some of the statistics in 2 different countries. And I have 2 different sources here related to Mexico with a focus on Mexico City. And so alone, Mexico City, which is known as the city that has a lesser poverty rate, 28.6% alone, it does impact the residents' access to healthcare, secure homes, and food insecurity and overall social deprivation. This is another interesting one that I found in one of the articles. 52.8% of these citizens have been victims of crime, and 91.3% of its population feels unsafe and impacts both the mental and physical health of the citizens. The low socioeconomic status has been linked to education attainment, which I talked about earlier, and further ties to morbidity and mortality related to diabetes. There's also a reduced diabetes self-care knowledge deficit leading to reduced glycemic control, meaning reduced at-target diabetes control associated with more of a suboptimal diet, neuropathy, which is one of the complications related to diabetes, and reduction in overall healthy foot care, meaning wearing proper shoes, making sure you don't have any cuts in your feet, making sure that any cuts, any exposure to harmful elements is taken care of. Healthcare access remains a challenge, including government policy to ensure healthcare for all. I personally am from Mexico, and I go there about twice a year to spend time with family. And I know that individuals that have the financial means do have to purchase medical insurance. Some do get medical insurance from their employers. And what I found interesting was that a lot of some of these pharmacies, at least one of the pharmacies in Mazatlan, Mexico, they have these doctors stationed at the pharmacy because they're not going to give you medications without a prescription. So you see the doctor performs an assessment, and it's relatively cheap. However, this is probably something simple as you know, you've got the cold, you have the flu, maybe an infection. But I was actually pretty impressed with the doctor that I saw with a few simple needs that I needed handled, and the cost was very, very cheap. However, what is it like when you have more complex needs? That's a whole nother ball game there. So as you can see by the diabetes estimates for those between the ages of 20 and 79 years of age, it's going to increase by fold in the thousands by 2049. Look at just the big jump from 2011 from 10,293. I believe this is in the millions up to 1762 back in the millions, and it's projected to get even worse by 2045. Complications in Mexico related to diabetes, we have our microvascular such as nephropathy or kidney disease, neuropathy such as nerve disease, retinopathy, otherwise known as eye disease. On a macrovascular level, we have heart disease, cardiovascular disease, coronary artery disease, which is very high in Mexico, peripheral artery disease, and heart failure is also very high at 4%, which ties into coronary artery disease. Okay. And I just need to flip to the next slide here. I think I went too far ahead. Okay, this is way too far ahead. This is an interesting figure that came from that same article related to the effects of diabetes knowledge and self-care behaviors on microvascular damage. So there's something called diabetes self-management education that patients here in the U.S. do receive if their insurance companies do pay for that. So a person living with diabetes will learn more about food, medication, what an A1C means, meaning the overall 3-month blood glucose average versus just a random blood sugar check. And let me just stop there for a minute. I worked with Dr. Brash at one of these public health outreach events, and we were doing our ADA risk assessments for the American Diabetes Association. And I was actually surprised at some people that scored high on the risk tests. And I asked, hey, do you get your blood work done? And do you know what an A1C is? And a lot of people didn't know what an A1C meant. So an A1C is one of the lab results that determines if you have type 2 diabetes, which is 6.5%. So if you score between 5.7 and 6.4, that's pre-diabetes. And if you get a score of 6.5 or higher, that is type 2 diabetes. So that's something related to diabetes knowledge on the left. Self-care behaviors could be related to food, again, reduction in processed food, reduction in calories if somebody, needs to lose weight, exercise, both aerobic and anaerobic exercise. So all of these things lead to improved glycemic control and a reduction in microvascular damage, and that's called self-care behavior. Okay, let me move the window to the left here. Interestingly enough, but not surprising, China is ranked second worldwide in diabetes prevalence, very high. I mean, look at the difference from the year 2000 to what the projected people with diabetes in the 1000s will be at 174,433, which I think is in the millions regarding to these figures. it is very high. It's very it's related a great deal in the aging process. Occurrence is related to the aging process, and more than 20% in the group ages 60 years and older have been diagnosed with diabetes. There are economic disparities tied to the more rural regions versus the urban regions. And one of the articles I cited here, I read about some of those living in the more rural areas or working as an agricultural worker may have experienced famine in the past. And now with now that there has been some economic growth, the body has not been able to tolerate the changes in the food today versus having experienced famine in the past, which I thought was interesting. Also, there may be some education attainment or information where they're not getting screened for diabetes. So they may not find out about their diabetes until they're experiencing some symptoms. And it may not be unusual that they're coming in with very high A1Cs, way above the 6.5 range, which we do see all the time at my healthcare institution. And so also the total cost of care for those living in the rural areas was almost double versus those in the urban areas, which is interesting. I wonder what factors into that figure why do things cost more in those areas? And healthcare reform has presented with challenges as well. The diabetes related health expenditure down below, it says here, total diabetes related health expenditure in US comes in the millions at 25, if this is the millions, 25,490,000. So it's also very, very high in China, which is quite interesting. Can I move this window to the right here? Just to add further to diabetes in the country of China, it's diabetes with a prevalence of 8.5 in the world population. It's the 8th leading cause of death in the world. And so China ranks second worldwide in diabetes prevalence, which is interesting. With 1/4 of the world's more than 100 million patients. And the occurrence of diabetes in China is positively related to aging, and with a prevalence lower than 3% in people younger than 45 years old. And 11.5% are in the middle age group, ages 45 to 59, and more than 20% of diabetes is found in the elderly, as it says here, ages 60 years or older. And so affected individuals suffer a greater risk of developing comorbidities and complications related to diabetes overall in different parts of the world, including cardiovascular disease, which we talked about in Mexico, physical dysfunction related to nerve disease, even some heart disease if you cannot exercise because of your heart condition, any injuries that you might have in lower extremities. And this impacts individuals, they have a greater risk of developing further comorbidities because of the complications related to diabetes. And half of the individuals with diabetes have at least one comorbidity related to it. And the situation is much more severe in the middle-aged and elderly population group. The pathophysiological nature of diabetes leads to a vastly increased need and demand for medical services. And so this does cause a high diabetes-related healthcare expenditure, as you can see on the lower right. And in China, the universal coverage of social medical insurance was considered a solution to improve health equity for all, coming from different socioeconomic status. However, it had its challenges. And what was found was that the medical insurance coverage rate for patients with diabetes had reached 93.7% in 2011. So the reform was also emphasizing the promotion of more equality related to basic public health services by establishing a system of personal health records for standardized physicians in China. But it had its challenges, just like we've had our challenges here in the US. And unfortunately, the number of public health practitioners, for some reason, were not as motivated or enthusiastic to work in the public health. It was just a weakened effort on the medical side, and that I do not know why. That's definitely something interesting to read about. For patients that came from low socioeconomic status, they suffered the most. And public health management is the most important and effective measure in covering primary, secondary, and tertiary prevention to reduce individual healthcare costs and, of course, reduce morbidity and mortality related to diabetes. So this is definitely a big challenge for policymakers, not only in China, in the US, Mexico, and throughout the world. And move to the next slide here. So a number of inequalities were cited in our text for this week. Our text mentioned inequalities in the indigenous population in Australia. Again, coming from Mexico, I have seen a lot of inequalities in the country of Mexico with the indigenous population that resides there. And I'm glad that more efforts has been made to have more equality for the indigenous and finally embrace the indigenous population there. There is systemic racism. The indigenous population in Mexico, they do speak various dialects, and they may not speak Spanish, which is another barrier in the country of Mexico. So systemic racism is something that has occurred for years and years, and it's something that still occurs today, unfortunately, not only in the US and Mexico, but throughout the world. Thankfully, more attention has been paid to gender equality and human rights. Now, finally, not only are we talking about equal treatment for those from different cultural and racial backgrounds, but also gender equality for the LGBTQ populations. Just things as simple as getting a healthcare check. Medical practitioners have to be mindful of how they talk to people. They have to use the right pronouns, and just be mindful of the kinds of questions that are asked. Fortunately, the US has made great strides towards that, especially here in Los Angeles. However, it may be different in different parts of the country. Unfortunately, inequalities do exist in other parts of the world, which do not allow those from the LGBTQ group to seek medical care. And this could lead to further morbidity and mortality related to different conditions in health, and people will miss out on screenings for various reasons. We definitely need policy change. There are many implications for more equal health systems and services. And social exclusion. Social exclusion was also cited in our text. So social exclusion is often related to those coming from different socioeconomic backgrounds. It could be related to where they live. It could be related to their culture or their race, or I mentioned the LGBTQ population, the elderly, those living with HIV or AIDS. So there are so many groups to target to make sure that they get the proper treatment and fair and just treatment from healthcare practitioners and through medical services. So this was a very, very in-depth chapter when I read about the social determinants of health. And the social determinants of health apply to different countries on different levels, and we are more inclusive here in the US, but really, how inclusive are other countries or countries going through civil war? So there are just so many barriers to good health, and I have to say we're lucky to be here in the US where we are more inclusive today, although we still have a long way to go. I did complain about the patient that I connected to a physician, but luckily he has the Medicare coverage to pay for his insulin, to give him his continuous glucose monitor, and to see us on a regular basis. He was very happy and content to just get care from us, which made me sad because in reality, he did not know how to ask for help. He did not know that, hey, it's not okay to wait 6 months to see a doctor. I don't care who I see in any language, because we do have services to translate for our medical practitioners in different languages. So I was saddened with that experience, but at least he's getting the care that he needs. Thanks to the existing cultural diversity in the US, we get to explore various inequities that have experience from different racial, cultural backgrounds, or from different groups, such as the LGBTQ groups. Social determinants of health continue to be linked to increased morbidity and mortality rates in various conditions, including chronic disease, such as diabetes. Again, I've had clients come in and didn't receive a whole lot of education or know from their respective countries. When you read the literature about diabetes and the social determinants of health, I think I came across an article talking about the functional illiteracy that exists here in the US or Los Angeles, where there is a functional, where they're getting by, but illiteracy related to their ability to read or write. And so people are afraid to ask questions. They're afraid to engage with their healthcare practitioners. Not everybody. I'm happy to say not everybody is afraid, but many people are afraid. What else? I was talking to somebody recently where he said he grew up in a food desert. So when you're growing up in a food desert, you're growing up in an area where you're not going to you're not going to have the bigger supermarkets with fruits and vegetables. And what is the cost of fruits and vegetables at supermarkets? Are they a lot more expensive versus just getting some fast food? Socioeconomic status is huge. It's a huge barrier for getting healthcare and healthcare access. And of course, it ties into other aspects of healthcare, such as education attainment, being able to just drive yourself to the physician's office, not having transportation, not living in an area that's safe, whether it's here in the US or other places in the world like Mexico City, where the crime rate is really high. And because the crime rate is really high, how safe are people going to feel about taking a walk outside or going for a jog? Are you going to get robbed or attacked? That's a big deal. So we have a lot to target, not just targeting, okay, this person's having, I don't know, 3,000 calories a day, but let's dig deep and find out more about this person, where this person grew up, find about their education, their healthcare services throughout the years. Did they get any? There's so much more to target and find out. So more exploration and research needs to continue to be done to further target social determinants of health. Luckily, I just got back from the American Diabetes Association scientific sessions, and there were a lot of talks about social determinants of health, a number of talks targeting obesity. As you know, there are different more comorbidities related to obesity, such as diabetes and heart disease, and other conditions such as fatty liver disease, and so forth and so on. And so we're targeting obesity, we're targeting biological factors that cause obesity, behavioral factors, and even medications that are targeting obesity. At the same time, not everybody's going to have access to these medications that help facilitate weight loss. which is really sad for such a big problem right now. There needs to be an increase in public health outreach targeting marginalized communities in the US and throughout the world. It's going to continue to be essential. We have to go out in the communities. We have to perform screenings such as other places throughout the world. Check the blood pressures, check the blood sugars, educate on what an A1C is, connect people to healthcare services. Like, hey, I know you don't feel anything. But your blood pressure today was 150 over 100. That is above target for your age. Let's check your height weight ratio. Let's do an ADA risk test and see how high you score. Let's see if we can connect you to an office, a healthcare office, and let's do an A1C and find out if you do have diabetes or pre-diabetes. Because now we need to work more on preventative care. And of course, secondary and tertiary care is critical, but let's target preventative care to prevent diabetes if possible, or prolong the diabetes until later on in life. And this is where we need to bridge the gaps between communities, both in the US and throughout the world, to healthcare services and provide education to promote health further. Thank you for your interest. And I need to end the recording. And these are my references. And I just